pulmonary artery arching over the left main bronchus. E is a left hemidiaphragm, and you can see the gastric air bubble F below the left hemidiaphragm. G, right dome of the diaphragm. Right pulmonary artery H. Right main bronchus I, and the azygous vein J. Exercise 8 is a lateral view of the chest radiograph. A is the aorta, B pulmonary conus, C right ventricle, D inferior vena cava, left ventricle E, left atrium F, and trachea G.
Let's take a look at some of the chest x-rays. This patient came with hemoptysis, has a cavity in the left apex and a ball inside that cavity. This is a case of pulmonary aspergilloma. This patient with chronic cough and purulent sputum had multiple cystic lesions in both lung bases. Cystic bronchiectasis. Can you see the horizontal fluid level in the left hemithorax? This shows that there's air and fluid. This is hydropneumothorax. This is different to a pleural effusion. This patient presented with acute severe shortness of breath. A snowstorm pattern or a batwing appearance was seen in the lung fields. Cardiothoracic ratio was more than 50%, showing that there is cardiomegaly. This is an example of gross pulmonary edema. This patient presented with hemoptysis. He had multiple rounded opacities of different sizes. These are called cannonball secondaries. In this patient, the primary was in the testicle. Spot what the radiological abnormality in this case is. He came with pleuritic pain and sudden shortness of breath. You can see the edge of the lung separated away from Later, we inserted an intercostal tube connected to an intercostal drainage system. You can see the air fluid level moving up and down, and when the patient coughs, the air comes out the tube. This is a water seal drainage system. This is the chest X-ray showing the intercostal tube in the pleural cavity. It's another patient who presented with fever and weight loss. The field showed small pinhead size opacities, and the right mid-zone there was a cavity. These are miliary shadows. Let's take a closer look. You might see it a little more clearly. This patient had miliary tuberculosis. This is the classical appearance of right mid-lobe consolidation. One of the cardinal signs of the consolidation is the presence of air bronchogram, which you might see on this chest radiograph. That shows that the shadow is in the lung parenchyma, not in the pleural cavity. This is a pleural effusion. Can you see the homogeneous opacity in the lower part of the right hemithorax with a concave upper margin? This is different to hydropneumothorax, which you saw in a previous chest radiograph, which had a horizontal fluid level. Fluid was aspirated. And it turned out to be blood-stained. Pleural aspiration and analysis of the fluid and pleural biopsy are two important investigations in case of pleural effusion. The fluid was sent to the lab for cytology, estimation of protein, sugar, culture, and other microbiological investigations. CT scan is useful when you want to investigate the mediastinum and also for certain parenchymal lesions, for example, fibrosing alveolitis, and also in bronchiectasis. It's also useful for aspiration of lung lesions that is done under CT guidance. This is a case of fibrosing alveolitis. Chest radiograph showed bilateral honeycomb appearance. CT showed that these changes were confined to the posterior basal areas and extending into the lung. This man with hemoptysis and confusion had a large right upper zone opacity. On lateral chest X-ray, the consolidation of the apicoposterior area was seen. CT scan of the head was done, showed secondary surrounded by an area of edema. This patient had bone pain. Therefore, we proceeded with this investigation. Do you know what this is? This is a technetium bone scan. The dark spots are secondary deposits. He had multiple deposits in the bone. This triangular shape, pleurally based lesion is a pulmonary infarct. Symptoms are hemoptysis and pleuritic pain. But sometimes if the infarct is large due to massive embolus, patient can present in collapsed situation. This investigation was done to confirm that this is a pulmonary embolism. This is a perfusion lung scan multiple filling defects here show that there are multiple infarcts. To confirm that this is due to infarcts, one has to do a ventilation scan and show that these filling defects are well ventilated, but not perfused. This patient had a massive pulmonary embolism, had a pulmonary angiogram, and one can see one pulmonary artery is completely occluded.
Bronchoscopy is an invasive investigation. It is used when the malignancy is suspected. In case of infection of the immunocompromised host, where you want to take samples from the bronchial tree. In case of diffuse interstitial lung diseases, when you want to biopsy the lung parenchyma. And also undiagnosed cases of lung opacity, for example, coin lesions on the chest radiograph, and in cases of hemoptysis when the chest radiograph is normal. Following lung transplantation, rejection is detected by doing multiple lung biopsies through bronchoscopy. There are several therapeutic uses of bronchoscopy as well. It is used for removal of foreign bodies, when they are segmental collapsed for removal of mucosal plugs, and also endobronchial laser therapy. Bronchoscopy is done under local anesthesia. Local anesthetic gel is applied to the nostrils and also sprayed into the throat. Bronchoscopy is done without any sedation, without general anesthesia. The scope is passed gently through the nose, and certain sensitive areas within the tracheobronchial tree is sprayed with local anesthetic. This is a vocal cord, very sensitive area, which is sprayed with a lignocaine spray as you go on. The trachea, main bronchi, and main carina, another very sensitive area. You can see the purulent secretions and erythematous mucosa. Case of acute bronchitis, here you can see edema and the orifice is narrowed. There's a bleeding into that. This is a case of malignancy. This polypoidal growth turned out to be a squamous carcinoma. You can see the bronchial orifice is narrowed by about 80%. One can undertake several procedures through the bronchoscopy. Bronchial brushings, and brushings are sent for cytology. This is the biopsy needle. Bronchial washing are also sent for cytology. Biopsy of the bronchial lesions as well as abnormal looking mucosa can be undertaken through the bronchoscope. When the biopsy needle is passed through the parenchyma, one can obtain a transbronchial biopsy of the lung parenchyma. Washing of a segment of the lung parenchyma is called a bronchoalveolar lavage. This is a needle, a bronchoscopic cytology brush, biopsy, forceps, and the bronchial trap used for bronchial washings. A bronchial biopsy. Saline is instilled in through the bronchoscope into the bronchial tree and washings are obtained. Washings are sent for cytology. This is a bronchial brush smear. The samples are then sent to the laboratory with detailed request forms.
Cytology is useful to diagnose bronchial malignancy, to determine the cell type, and also in certain chronic inflammatory conditions. Let's look at some of the slides now.